Good afternoon. It is 1:34, so we'll go ahead and get started if we may. I'm Dr. Beidel's room monitor today, so I want to remind everybody please to enjoy, ask questions at the end, and have fun with the presentation today. Dr. Beidel is a professor of psychology at the University of Central Florida. She's authored over 200 scientific presentations. She's utilizing technology to disseminate efficacious treatments for anxiety disorders into standard clinical practice. She's funded by the U.S. Military Operational Medical Research Program. She is examining the efficacy of virtual reality programs that use sight, sounds, and olfactory stimulation, such as in virtual Iraq, to enhance proven treatments for combat-related PTSD. She's also funded by the National Institute of Mental Health to develop and test the use of virtual environments to treat children with social anxiety disorder. So if I may, let me introduce Dr. Deborah Beidel. She's using virtual reality to treat real anxiety and PTSD here today. Thank you.
Thank you. What I'm going to talk about this afternoon is really the program that we have to treat veterans from Iraq and Afghanistan who are suffering from post-traumatic stress disorder. So a little bit different than some of your other presentations, I imagine, that we're not going to spend a lot of time talking about how the game or the virtual environment was developed, but really more to talk about how we use this virtual environment as part of our overall treatment program. And I'll be sharing with you some of the actual virtual environment clips that we've brought, and also talking about some very, very preliminary outcome data. This is a 5-year project in which we are just starting the 3rd year. The program is open to anyone who has served in Iraq or Afghanistan, has come back and is now suffering from post-traumatic stress disorder. So we treat in our program at UCF active duty, we treat veterans, we treat Guard, we treat reserves, we treat civilian contractors. The underlying unity that holds everything together is the fact that they've been deployed, they now have combat-related PTSD as a result of that. So I always like to start off by just talking a little bit about, we'll learn how to use this, there we go. What is post-traumatic stress disorder, sometimes known as PTSD, because it's a word that people throw around, but it's not always the same word. We're not always talking the same language. But basically, what we're talking about with this disorder is we're talking about exposure to an actual event that has resulted in either the actual death of someone, threatened death to yourself, some kind of serious injury or threat to your physical integrity. And there are 2 kinds of post-traumatic stress disorder, which is why you see both of those pictures up there. The top one is to represent what we refer to as civilian post-traumatic stress disorder. So things like either being witness to or having been in the towers on 9/11, sexual assault, physical assault, people who may have been in concentration camps, people who are the victims of some kind of violent crime we consider to be part of civilian post-traumatic stress disorder. And the other, of course, is combat-related post-traumatic stress disorder, which if you look in your history books goes all the way back in time, although it's been called by many different names. It's been called soldier's heart in the Civil War. It's been called battle fatigue, anxiety neurosis. All different kinds of words have been used to describe this. We've now adopted the term post-traumatic stress disorder. It involves a number of symptoms. It involves symptoms of what we call intrusiveness. So basically, these are times when a person who will be sitting here in a room just like where we are now will suddenly have thoughts or images or almost feel as if they are back at the scene of the traumatic event. So people will have almost what we might think of as visual hallucinations. We call them flashbacks, the feeling that they're once again back in that particular situation. People will also talk about nightmares that they have that might also be somewhat intrusive. There are also symptoms of avoidance. So a lot of the men and women that we work with will talk about not being able to go certain places, not being able to do certain things. A big one for many of the people we see is an inability to go to places like Walmart, which are really crowded. And there's lots of people that you have to watch. And so not being able to do that because of this sense that you can't control everything around you, you can't monitor everything that's going on, you don't really know what's happening. And people talk about not being able to fill up their car at a gasoline station because of that smell of diesel fuel, which then might trigger a traumatic event. Another symptom is numbing. It's very interesting. Although this is a disorder that's associated with a high level of anxiety, people often talk about an inability to feel any other kind of strong emotion, particularly positive emotions. So an inability to feel affection, an inability to feel love, feeling of just not being able to feel at all except for anger and sometimes, and also anxiety. People talk about a foreshortened future in the sense that many people with this disorder will say, this has changed me so profoundly that I don't think I'm going to live as long as other people. Not so much that they want to take their own life, but they just feel in some way this has changed them to their core and their life is never going to be the same and it's going to be shorter. And finally, hyperarousal, which is the symptom that most of us are in psychology and psychiatry are most familiar with. This feeling of being on edge all the time, of being jacked up, some people say, having to monitor everything that's going on around you, that comes along then with sleeplessness. So many people with post-traumatic stress disorder, if they get 2 or 3 hours of sleep a night, that's a good night. And being unable to come down and relax and unable to give up these feelings of surveillance, okay? Having to sit in a room with your back to the wall so that you can see everything that's going on around you. A lot of people have combat-related post-traumatic stress disorder, and the prevalence varies significantly. But the best studies that we have suggest that we're talking about between 6 and 9% of people who are deployed and who come back. As you might expect, that rate varies depending on the type of deployment that you had. So for those who had an MOS that required that they were more the front line, more likely to take fire, more likely to be near an IED, those rates are higher than in the support troops. Also, epidemiological data suggests that from community samples, not combat samples, but community samples, this rate will drop over time. We think that combat-related PTSD is a much more chronic condition without treatment than things like automobile accidents, physical assault, natural disasters, those kinds of things. Also, the Vietnam veteran population is a little bit difficult, and more recent studies are suggesting that the rates might be lower than they were originally suspected to be, because those rates were considered to be a lot higher than 6 to 9%. And we're finding that there are fewer cases of functional impairment, suggesting that really maybe over the long term, there might be some recovery of functioning, although that's still based on just a few studies and is still somewhat unclear. And studies of non-US forces suggest lower rates, but we don't know exactly why that is. There's some concern that the diagnostic procedures may be different in different countries, that certainly the pension and compensation rates are different in different countries. So we're not sure why those rates are different. We know that, particularly in the last war, there really wasn't any difference in the rates of combat, but it does seem to be a difference in how people are treated and what happens once they get home. Here in the United States, we find that this is really a significant problem, which is why the military has invested a significant sum of money in the treatment of these disorders. If you look at this graph, what I'm trying to show you with this graph is on the bottom you'll see the treatment year. So these are people who have come home and in their first year of treatment have used our Veterans Health Administration for services. And then the next segment is the second year, the third year, and the fourth year. And if you look at this continuation, what you can clearly see is that those who have post-traumatic stress disorder or traumatic brain injury, or both, are not getting better despite the services that are available to them through the Veterans Administration. And so unlike people with other types of disorders, even people with physical disabilities, the rates of people with these disorders are just not improving over time. We don't have very good treatments, and in some cases, when we have good treatments, we don't have a lot of therapists who know how to do those particular treatments. According to the Institute of Medicine, there really are no medications that are effective for post-traumatic stress disorder. Now, there are some that will work on symptoms of the disorder. There are some sleep agents, for example, that might help with sleep. There are some antidepressants that might help a little bit with anxiety or with depression. But there are no pharmacological treatments at this time that really seem to be effective for the core symptoms of this disorder that I described to you recently. There is data, however, there are data that would suggest that behavior therapy called exposure therapy certainly is effective for civilian post-traumatic stress disorder and may also be effective for combat-related post-traumatic stress disorder. And according to the Institute of Medicine, the only effective treatment, the only treatment for which there are any data at all as far as a non-medication treatment for post-traumatic stress disorder is exposure therapy. And that's what I'm going to talk a little bit about next. So what is exposure therapy? If we talk about anxiety disorders in general, of which post-traumatic stress disorder is one, we're talking about the need to come into contact with the event, the situation, the object that creates anxiety for that person. Okay? So if they need to somehow, in some way, be in contact with that. And when I talk to people about exposure therapy, the usual example I give is, how do you get over your fear of a dog? Right? If I ask someone that, they say, well, I've got to be around a dog to get over my fear of a dog. Yes, that's exactly right. The issue is, though, you have to be around the kind of dog that's associated with the trauma in the first place. So if you were bitten by a German Shepherd and I bring in a Chihuahua to do treatment, that's not going to work. Okay, not only because it was the wrong size. If you were bitten by a Chihuahua and I bring in a German Shepherd, that's not going to work either. When we do exposure therapy, we have to put the person in contact with what it is that they're afraid of. And it's not just as simple as saying, oh, a dog, I'll go get a dog, you know, I'll go get this, I'll go get that. So that dog, which is my grad student's dog, it has to look like the dog that elicited the fear in the first place. So, how do we do this? Okay? If we're talking about having to put people and expose them to what it is they're afraid of or what it is that created that traumatic event, how do I do this? I doubt that UCF would want me doing this in the middle of Memory Mall. So we have to figure out another way in which we can expose people to the situations or events that created that trauma in the first place. Now, virtual reality is, and I'm speaking to the choir, has been used and is being continuously used and even becoming more common in the treatment of anxiety disorders. It's been very useful when we talk about phobias and fears, when we're talking about things like airplanes. So many people have difficulty getting on an airplane. And back before 9/11, I had a deal with US Air that I could use the planes when they were finished at night. They would literally open the door and tell me, come back and find me, I'll be in the office. When you guys are done with the plane, come on back and I'll lock up. Can't do that anymore. So virtual reality has come about to begin to help people become as exposed as possible or get into contact as much as possible with those particular events. So when we can't actually go and get a dog because they're not afraid of the dog, when it's something that's difficult for us to do in real life, we have to either depend on a person's imagination, which sometimes works, or we have to use something like virtual reality to recreate the specific fear. Using imagination sometimes works, but on the other hand, people will often say, I've been trying not to think about these things. It's totally irrational for you to tell me that now I've really got to focus on this, I've really got to think about this particular situation. So often in therapy, people will sometimes fight the actual exposure situation if we're asking them to do it in their minds. So the virtual reality has a lot of advantages because using a head-mounted display, it's much harder for people to not get immersed in a particular situation. Now, when we do virtual reality, we do it very individually and very uniquely. So if someone has served and they've been involved in a particular combat situation, we don't just say, oh, we have combat situation A, imagine this. We tailor the virtual reality, including all of the different elements, in order to recreate specifically what that person was afraid of. So it's not as simple as saying, oh, a tank exploded, oh, here's a tank. It doesn't work that way. We also have to use all of the channels that are necessary. So again, just like when I said, you can't use a Chihuahua if you really need a German Shepherd, we have to, in order to get the treatment to be effective, expose people to the sights, the sounds, the smells, the feel. We have to get all of those senses involved and create the best possible exposure scene in order to get the best possible outcome for that particular person. Also, with the younger men who are coming back from Iraq and Afghanistan, virtual reality has another advantage, and that is that it doesn't look anything like the therapy they're used to, okay? So, or the therapy that they've heard about. Okay, they're not going to come in and lie on someone's couch and, you know, talk about their mother. So it's a much more active, much more engaged situation, and people are more likely to want to at least give it a try and become interested in participating in the treatment sessions that we have. We talked a little bit about the scanning, and one of the things that many of the warriors have told us is, you know, I can't drive down I-4 because I'm too busy looking on the side of the road looking for something that might resemble an IED. And I know there's no IEDs over here, but I can't help it. I just do that anyway. The other thing that has become pretty interesting and pretty common is the idea of smell, olfactory cues. And what people will say is that there were unique smells associated with Afghanistan and Iraq, and those particular smells are triggers for them. And a colonel that we had recently who just came over to see the equipment was talking about the smell of the country, and you know, he didn't really believe that the virtual reality would be effective, and so we asked him, what does it smell like? And he said, it smells like garbage and body odor. Well, we've got garbage and body odor, and we put it together and we gave it to him, and he went, oh yeah, that's the smell. So we can recreate the different types of smells that are necessary. As I said, smells of cooking or burning, barbecues, unfortunately, often bring up a lot of traumatic memories for those who have been over in Iraq and Afghanistan and have been exposed to particular traumatic situations. Well, why olfaction? For several reasons. First of all, from basic learning theory, what we know is that olfactory learning is a very powerful form of learning. If you think about brain anatomy, from your olfactory bulb to your amygdala, which is your fear center of your brain, that's a very short run. It also has no connections. It's like a straight superhighway with no branching. Those memories and the smells that are associated with those events get burned into your amygdala a lot faster than any visual that you see, any sound that you hear. It's fast, it's powerful, it makes it extremely difficult to process or reprocess those traumatic memories if you don't include the sense of smell. There's something that happens in our brain that makes that very powerful and very difficult to get rid of. So, as we say, these odors that become associated with traumatic event can really set off the flashbacks and the hyperarousal. And all of these smells have become an important part of what we do when we do the treatment for individuals with post-traumatic stress disorder. What we're using is a system called Virtual Iraq. Now, in disclaimers, UCF and I did not develop Virtual Iraq. Virtual Iraq was developed by Skip Rizzo at the Institute for Creative Technologies in collaboration with the people that you see on the slide, and in particular with money from the Office of Naval Research, and now more funding through TATRIC as it continues to be improved. Here at UCF, we're one of the 3 places in the country that is actually testing the efficacy of using this system. The system is in a lot of places. It's being used in a few places. It's not being used in a lot of places. Unfortunately, talking to someone yesterday, there are many places where the system is still sitting in a box in the corner of the room because people don't know how to use it and they're not sure that it would be effective. So we're funded by the military, by the Army, although we're not limited to the Army, to conduct 2 different trials. We have a 17-week program that is really mostly for people locally in Orlando who are interested in receiving the treatment. Colonel Castro, who is the person who funded these projects through the Army, after the first meeting I met with him and we had the program going, he said, it's a great program, I think it's going to work. Can't have active duty soldiers out of active duty for 17 weeks. So we developed a 3-week program, which is an intensive treatment program where people from all over the country come down to Orlando. Everything is funded by the military except their flight to Orlando, but once they get here, everything is on the research grant. They stay here for 3 weeks and they get the treatment, full treatment program in a very intensive 3-week fashion. Now, I'll show you some data a little bit later, but the bottom line is that doing exposure therapy in this kind of intensive fashion actually works as well, if not better, than doing it in an extended fashion. There's about 50 years of scientific research to show that the closer together you do the sessions, the better the treatment will work. So we have both programs up and running. We're going to end up with 180 participants. We're still recruiting because we're still halfway through the project. But at this point, both of the other programs seem to be having a lot of effectiveness. And what you can see is, I can show it, use my pointer on this side, is this is what it looks like. So we're not using big, shelves or anything like that, big environments. It's basically a regular computer, 2 screens. One screen has the environment on it. One screen has what the person, the clinician will do. Of course, it's all clickable. Click on lots of different things. I'm going to show you some of the clips in a minute. And the person sits there wearing a head-mounted display, wearing the earphones, using either a rumble pad or in some cases we have a fake replica of an M4 that they can hold and navigate through the city, because some of them said they felt silly trying to navigate through the city holding the rumble pad. So we have that, and usually they're seated on a platform that has great big speakers on the bottom, so when something explodes, it rumbles, and you get the sensation, the feeling as if you were actually in the explosion. So. But that's basically what it is that we use in the situation. So it can be in a very small room. Don't need a lot of equipment or a lot of space in order to do this. Okay, so now what I'm going to show you here is a clip of a Humvee. I'm not sure there's actually an attack on this, but what I want to show you with this clip, and I'm hoping we have sound as well because we need that, is that I'm going to show you how this works, and what I said before about the uniqueness of this is that we can, using virtual rack, recreate exactly what happened. So what you'll see is if a person says the attack occurred in the morning, we can make it morning. If it occurred at night, we can make it night, put night vision goggles on. You'll see it go through several different scenarios. So this uses a typical Wizard of Oz interface on the other computer where people can click and the therapist can add different things, and we'll be adding some sounds in the next one that you'll see. And also, it does have 360 degrees, so as you turn your head, you see people to the right or to the left or up or whatever it is. So it allows a full immersion of the environment. So this is a city environment. This is a city roof scenario. Sound up a little bit, maybe. Thank you. So again, when they're in this situation, we would stop this wherever we might need to in order for them to occur. So if they said the attack occurred up on the roof right there, we would put them in that part of the situation. We could have things exploding. I'll show you one of those in a minute. Have different kinds of helicopters going by. We could have different sounds of the city. Next one I'm going to show you is a city marketplace. So you see there's some piles of garbage there, and as they walk by those piles of garbage, we can hit them with the smells that would be there as they were walking by, as they remember them. People can be taken in and out of the scenes. So if there were women or children or whatever there might be. That's all right. I think that might be the end of that one. The next one I'm going to show you is actually sort of full force, an actual attack that's going to happen. So I'm just letting you know because there'll be some hopefully loud sounds. But anyway, go ahead. How it works perfectly in your office before you come to the meeting, and then you get here and it just sort of falls apart. But if you could have seen it, as someone was going down, there are a lot of things that can happen as the attack occurs. If people say they remember that there was lots of damage on the windshield, you can add damage on the windshield. If the person next to them was hurt, we have different levels of what are called damage to the person next to them. We can have, if there was no one in the seat next to them, we can take the person out if they were riding rather than driving. So it's uniquely customizable to really get at specifically what the individual's traumatic event was. So it allows us to really customize the scenario for that individual. The good thing about exposure therapy is that it works really well when you're talking about those symptoms of hyperarousal and numbness and having trouble sleeping. But what it really doesn't work on is the negative parts of what we call post-traumatic stress disorder. So the anger, the guilt, the depression that often comes along as part of this disorder. And also the interpersonal difficulties and the social withdrawal that are often common among people who have post-traumatic stress disorder. So part of our funding from the military was to develop an additional component to exposure therapy that would address these different parts of the condition. And based on some studies that we did with Vietnam veterans back in the 1990s, identified a couple of different interventions that really seemed important to do. And some of those were anger management for sure, and helping people learn a different way of dealing with feelings of anger and rage. Also, some social skills training in the case of Vietnam veterans who had been withdrawn from people for 30 to 40 years, teaching them how to interact with other people, even to the point of saying, I don't even know how to talk to my family anymore. It's been so long since I've called my son or my daughter. So some basic ideas of how do you get people back out and back functioning in the community. And somewhat naively on my part, talking to 60-year-olds and having them trying to kind of go out in the community, and I would say things like, don't you want to make some new friends? And they're like, no, I don't want any new friends. I'm 60 years old. But they were interested in reconnecting with family and reconnecting with old friends and really getting back some part of their lives again. And then what was more relevant for some of the Vietnam veterans were things that we called veterans issues, which was, for those of us who are old enough to remember, when people came back from Vietnam, soldiers weren't treated very well, and they were called baby killers and those kind of things. So to teach the veterans how to deal with those kind of ignorant comments, which thankfully we haven't seen that much of in this new conflict. Our program is set up, as I said, we have 2 phases. The first phase is really 15 sessions of exposure therapy. And we do that because, as I said before, the closer together we get the sessions, the more we are able to get control over those symptoms of hyperarousal, get rid of the nightmares, help people sleep better, get rid of this sort of feeling of being tense all of the time. And then in the second session, so the exposure session is all individual. Those are individual treatment sessions. The social and emotional rehabilitation we do in small groups. And everybody fights us the first day of the group. I don't want to be in a group, I don't want to talk to other people. But again, what they find out is that this is a very skills-oriented, action-oriented group. And at the end, and I've had a number of people tell me that they actually feel the group was one of the best parts of the treatment, because they got to work with other people, got to share ideas, trade suggestions in doing that. So we do, in that group, we do anger management therapy, we do behavioral activation for depression, and we work on decreasing social isolation. This is really just the outcome of this particular study, as I said, which is funded by the Army. We are using these different cues, and we are also looking at economic cost. One of the things we're going to be able to talk about at the end of this intervention is what is the likelihood that we can change that trajectory that I showed you earlier, that we can get people to stop using as much medication, stop being in need of so many appointments at the VA or private therapy clinics, and get them to be decreased health costs, as well as improve their personal well-being and their social functioning. So, and we're also looking at specifically what is the role of olfaction. So we have a study that will be mounting very soon, looking at the amygdala and looking at using fMRI to look at changes in behavioral activation from these particular smells that are triggered both before and after treatment. And this is very important in the sense that it's looking at outcome that's not filtered by self-report in some ways. So it'll allow us to look directly at brain activity and brain changes before and after a behavioral treatment as well. So can we use behavior therapy to actually change brain functioning? I've got the 5-minute signal, so I'm going to go on a little bit. We've talked about the design and methodology a little bit. One of the things that I've said earlier, and one of the things that Skip Rizzo, who developed this, and I agree on to a great deal, is that we don't want anyone to think that the virtual reality is the treatment. Okay? The virtual reality is not the treatment. The virtual reality is a tool that we use to make the treatment better. And so we're collecting data that look at how many of our participants say, yeah, that's like it was when I was over there, or no, that has nothing to do. So there's a new version of Virtual Iraq coming out hopefully next month, and it's been rebranded as Brave Mind. But and a number of us who were conducting studies worked with Skip on revising it, because we had one person, for example, who was grabbed by some insurgents the first day he was in Iraq and held in an airplane hangar for 3 days under threat of death. Well, we don't have an airplane hangar in virtual Iraq, so in that case we didn't have a visual that we were able to use with him. But he could close his eyes, and we had sounds and we had smells, and so we were able to use those two channels with him. We also had a Marine who, looked at the uniforms in that guy in the Humvee and said, "That's Army, I'm a Marine, that's distracting me." So in those cases, again, not able to use the visuals. So what we're collecting for the Army, and this is based on number of people that have gone through so far, is what particular combination of the virtual environment did we use with each particular individual. And as you can see there, the most common combination is really sounds and smells. So, which is why the new version is going to have a lot more scenarios in it than the old one did. So we'll be collecting data and looking at that. But the good news is that it really doesn't seem to matter, that the outcome hasn't really been different based on which combination that we used. I spoke a couple minutes ago about the fact that lots of places have this equipment and it's sitting in a box because no one wants to or has used it. One of the reasons is a number of therapists believe that if they do this, people are going to fall apart, or people are going to get suicidal, or people are going to something. And so another thing that we've been doing is collecting data on people's reactions and outcomes. So when people come to our clinic every day, we ask them, how much are you drinking? What kind of suicidal thoughts have you had since the last treatment session? The CGI is a clinical rating of improvement. Like, how are they doing? Is there, according to the clinician, does their symptoms worse or better than the last time? And as you can see, over the 5 weeks that we do this particular treatment program, people are not drinking more. People are not having more suicidal thoughts. Exposing people to these events and having them reprocess their memories does not create these negative events that everyone thinks it does. Now, if you've never done this therapy, you don't want to do it without training and supervision. But the bottom line is that despite what people think, this therapy does not make people worse. People do not fall apart as a result of it. It actually is very effective in what it's supposed to be able to do. So this is the preliminary outcome. This is a self-report scale called the PTSD checklist. And the important thing to know about this scale is not only do symptoms improve at post-treatment, but the cutoff for PTSD is considered to be a score of 45 on that scale. So we're getting right below it. Many of our people are no longer meeting diagnostic criteria for post-traumatic stress disorder. I'm going to skip that one in the interest of time. But this is something called the Clinician's Assisted PTSD Scale. And this is the diagnostic scale that's used for people to determine whether or not they meet diagnostic criteria for post-traumatic stress disorder. And a score, again, of 45 on this. I'm looking at my colleague sitting in the corner, but it's, I think it's 45 on this scale, is really looking at people who no longer meet diagnostic criteria. And basically what we find is at the end of treatment, about 70% of the people we've treated so far no longer meet diagnostic criteria for post-traumatic stress disorder. The others are better. They're not without symptoms, but they're better. So we're getting some pretty dramatic drops in treatment, and a number of people are no longer meeting diagnostic criteria as a result of the intervention, which includes the virtual reality, which I do think plays a significant role for those for whom we're able to use it. This is not the kind of study that one does without colleagues, and so as I end this, I just want to thank my colleagues at various universities who have been part of this project and part of my work in treating veterans, which goes back to the mid-1990s and working with Vietnam veterans. So, and I want to thank you for your attention, and I think we have time for a few questions.
We do.
Okay.
Questions for Dr. Vidal?
Could you speak to the dropout rate in your study?
Yes, the dropout rate is probably about 30%, okay? And some of that is people drop out after the exposure therapy because they're a whole lot better and they don't want the group. We've only had, and some people move. Okay, and some people just can't come 3 times a week because they've got other things going on. We've only, to my knowledge, had 3 people who have either dropped out of the program or we've pulled out of the program because of some other type of disorder. You know, they may have been drinking a little too much, although in general we don't see that. So it would be wrong of me to say that no one has any kind of exacerbation, but there are people who come in with that in the first place. As you may be familiar, many people with post-traumatic stress disorder and many men in general who have anxiety disorders use alcohol as a way of controlling their anxiety and helping them feel better. So we often do find, well, not often, but you find that comorbidity exists. Yes, sir.
Ma'am, do you find that after exposure treatment, are people having relapse? Are they going backwards instead of forward?
That's a good question. In this study, we're funded out to 6-month follow-up, and we have found very low rates of relapse. We haven't calculated that yet. We do know that some people have some exacerbation of their symptoms at certain times when there's other things going on in their lives. So people who are facing foreclosure, for example, they're stressed out because they're losing their home. They sometimes then have more trouble sleeping. They may find that there may be some flashbacks that they didn't have a couple weeks ago. So they often have some changes in symptoms that occur as a result of other stressors that might be going on in their lives. The key to this treatment, which I didn't get into because we're not doing a real clinical workshop, is that these treatments have to be done for a certain length of time. Typically, a person has to be exposed to that session for 90 minutes. Okay? If people are exposed for a shorter period of time, if it's like 45 minutes and the therapist is going, well, I got another appointment, or the patient's going, I gotta go, you can actually make people worse that way. It's the wrong way to do the treatment. So what we're doing is, you can think about it as in reprocessing the emotion that goes along with the memories. So we're not saying that we're going to erase your memories, okay? And I say to people, anybody who tells you that they can get rid of those traumatic memories that you have is really lying to you, or is incredibly optimistic and should be named Pollyanna. But the idea is we're trying to remove and reprocess those memories so that those memories don't elicit panic attacks, distress, sleeplessness, all of those things. And a way of thinking about it that most of us might be able to relate to is if when someone very close to you dies, in the next weeks, maybe even months, every time you think about that person, you get teary-eyed, you feel sad, you may start crying. After a period of time, you can start to think about that person and you may smile, okay? You may still feel sad that they're not there, but you don't have that intense emotional reaction again. That's what this is all about. It's trying to give people back their lives here, let them be able to function again here without those anxiety symptoms and without never being able to go to a ball game, never being able to take their kids to Disney or Universal or wherever it might be.
One last question.
I found the chart that you showed relating to the correlation between olfactory and stimuluses, to be very interesting. And my intuitive version would have been that the visual images would have been much more powerful to them than olfactory or auditory. Yeah, your chart tended to show that for over 55% of the people, found greater relevance in. Is there any hypothesis as to why it turns out that way, or?
Well, the hypothesis that we think it really is has to do with, again, the very short, the neuroanatomy of how olfaction is processed in the hippocampus and in the amygdala. So it's getting back into that limbic brain system, that very, very reptilian brain, as some people call it, and the fact that it's very quick. There are no connections that have to be made like through the cortex or the prefrontal cortex to get back to the occipital lobe, where some of these things start to get degraded. So what we think right now is because it's so rapid and it gets in there to the amygdala so quickly, that very short neuroanatomy run makes it be much more powerful and much more capable of eliciting that typical fear response.
Thank you very much, Dr. Fire.